Good morning. It's my pleasure to be able to introduce Dr. Tarek Alsaied, one of my co-workers here. He is an assistant professor of pediatrics at the Heart Institute of CHP. He did a large part of his training in Cincinnati. There appears to be a Cincinnati connection here. He also did an advanced cardiovascular imaging fellowship at Boston Children's. He returned to Cincinnati after finishing his training, and then we were lucky enough to recruit him here to the CHP Heart Center in 2021. Anyone who knows Tarek knows he's very energetic and is actively involved in research and publications, and he has a very strong interest in the Fontan population and everything to do with them. He'll be speaking on advanced imaging today.
Thank you, Dr. Lanford, and thank you, everyone. It's really an honor and a pleasure to be here this morning. I will be talking about advances in imaging post the Fontan-Kreutzer procedure. We will start with an introduction and background, and then we will look at different imaging modalities used in Fontan-Kreutzer patients, and then we will finally look at the future directions. So let's start with some introduction and background. As we heard this morning, the procedure was created in the 1969, and then in the 1970s, there were multiple modifications with the removal of the valved conduits and the creation of the atriopulmonary fontan by Dr. Kreutzer. And then in the 1990s, there was creation of the modern types of fontan that we see today, which is the creation of the cavopulmonary anastomosis with lateral tunnel and extracardiac conduit fontan. And with that, there was significant improvement in the operative survival. And today in 2023, we see many adults with Fontan, and it's time to focus on the long-term morbidity and mortality. So looking at the long-term outcomes, this is the same paper actually that Dr. Silversitz used in the morning. So this is a paper from the United Kingdom with 7,000 patients with adult congenital heart disease and a median follow-up of 9 years. And it compared the survival of different types of congenital heart disease to an age and sex matched group of adults in the United Kingdom. And what you can see on this graph here is that patients with Fontan circulation seem to have the higher standardized mortality ratio compared to all types of congenital heart disease, including complex congenital heart disease and patients with Eisenmenger syndrome. So it's definitely a population with high risk for adverse outcomes. And based on that, we think about the journey of these patients on a roadmap, starting from stage 1 through the Glenn anastomosis, and then they go through the Fontan-Kreutzer procedure, and then many of them will end up needing a heart or heart-liver transplantation. And our goal as Fontan doctors is to try to delay or prevent transplantation, but also try to refer them for transplantation at the right time. And imaging plays a central role here because it helps us with risk stratification, and also it helps us with predicting mortality and morbidity. There's a nice balloon here in the room. So that takes us to imaging. So we'll look at different imaging modalities used in Fontan next. In terms of the preferred diagnostic strategy, there's really no one strategy that works for every patient, but we typically use a combination of echo, cardiac MRI, and sometimes CT scan when cardiac MRI is contraindicated. This is a scientific statement from the AHA that kind of guides us through how often to use these testings. So echocardiogram is typically recommended yearly, while cardiac MRI is recommended every 2 to 3 years. And we use cardiac CT in patients where we can do cardiac MRI. And this is, for example, patients who have epicardial leads. So to highlight how multimodality imaging can be very helpful in these patients, let's discuss a patient presentation. So this is a 24-year-old with hypoplastic left heart syndrome, aortic atresia, and mitral atresia. He had a baseline echo that showed low normal right ventricular systolic function. And then, unfortunately, during COVID, he lost to follow-up and fell into some substance abuse issues. Before this presentation, he had 1 week before this presentation, he had sudden chest pain at the gym while running. And since then, he had persistent dyspnea and dizziness with mild exertion. He presented to an outside hospital emergency department. His troponin was very elevated. His BMP was also very elevated. They did a chest CT, which was concerning for a pulmonary embolus in the left pulmonary artery, and thus was transferred to our hospital. This was Friday afternoon. I remember I was on call, and I called Dr. Saraf that day because she was on call for ACHD. So looking at his echocardiogram from the emergency room, you can see, from 2019, this is his baseline echo. You can see that his RV has reasonably well functioned. And then as we look at the echocardiogram from the presentation in 2021, you can see that the right ventricle was severely dilated with severely depressed function, and there is a small pericardial effusion. Next, when we sweep anteriorly towards the aortic valve, we see that there is a filling defect in the right ventricle here, and it's pretty echo bright, so that was suspicious for a thrombus. And then looking at his coronaries, you can see that we can fill his right coronary with color, and then we try to look at his left coronary as well, but it does not fill with color. So the echo report is that his RV function was severely depressed. There is an RV thrombus, and that the left coronary origin is not well seen, and there is a small pericardial effusion. So let's just talk very briefly about the pros and cons of echo. So the pros is that it's portable and widely available. There is always an on-call fellow who can go to the emergency room and do an echocardiogram. In this case, Dr. Gonzalez is here. Actually, she did this echo. It's a great tool for valve assessment, and it has high resolution. But the problems with it is that it requires some experience in congenital heart disease, and also we have limited RV functional assessment, especially quantitatively, and the acoustic windows can be limited. Next, we look at his CT scan from the outside hospital. So the bright structure here is the superior vena cava, and you can see this is the filling defect in the left pulmonary artery. But as we go towards the Fontan, we see that the Fontan is not filling with contrast. So our suspicion is that this is just a contrast timing artifact rather than a real thrombus in the left pulmonary artery. And then when we were looking more carefully, so this is his native aortic root, so this small structure here, and you can see the right coronary is coming off it. And then you can see that there's maybe a small filling defect in that native aortic root. So the CT read from the outside hospital is that there is left pulmonary artery large embolus. After we carefully reviewed the images, we thought that the LPA thrombus is less likely and that there is possible native aortic thrombus. The pros of the CT is that it has rapid acquisition, so we can get it very quickly in the emergency room. It has high resolution, and also it visualizes the Fontan pathway pretty well. However, the cons of this modality is that it involves radiation, and it does not give us any flow data, and also the contrast timing can be challenging, especially in these Fontan patients, and that was the case in our patient. So just to review his imaging so far, so we were concerned for native aortic thrombus, as you can see on this CT here, and then when we carefully review his echo as well, we noticed that even in the echo, we couldn't fill that left coronary artery, and there may be a little filling defect here as well. And this is just to see where that filling defect I was talking about. So this is the native aortic root, and that's what we were thinking could be a thrombus. So because of that, he went the next day, so Saturday morning, he went to the cath lab, and in the cath lab, they confirmed that there is a native aortic thrombus. However, there was good flow seen in both coronary arteries, and he was pretty sick at that time, so we felt that the risk of trying to take this out outweighs the benefit. A few days later, he went and underwent a cardiac MRI, and you can see by cardiac MRI, this is his right ventricle here, and the function of that right ventricle was severely depressed. And then this is what we call the late gadolinium enhancement imaging, or the SCAR imaging, where the normal myocardium is usually black, while the SCAR, or the abnormal myocardium, is usually white. So this entire area is a SCAR here. So this patient infarcted a very big part of his right ventricle. Now we're going to spend a little time talking about cardiac MRI in patients with Fontan because we believe it plays a really important role. So cardiac MRI is good for cardiac structure, evaluating cardiac function, quantitative evaluation of the flow, and also tissue characterization. So when looking at the cardiac structure, we can look at the cardiac anatomy. We can look at the cardiac anatomy. As we can see in this patient, this is a patient with double outlet right ventricle. The aorta is coming from the right ventricle here. There is a large VSD, and you see the subaortic conus. We can also do some nice arch reconstructions. So this is a 3D reconstruction of the aortic arch here, and we can tell if there's any coarctation. We can also look and see if there is, and I don't know why the videos are not playing on this, but we can also see if there's any pulmonary artery compression. So this is a patient with a severely dilated aorta, and that's causing some compression of the left pulmonary artery, which is common in these patients. And also we can look for Fontan pathway obstruction. So this is a nice 3D reconstruction. This is with IV contrast. You can see that the inferior part of that Fontan conduit is narrowed with dilation of the IVC and the hepatic veins. And this is another patient, and this is without contrast. And you can see that the conduit is probably diffusely small for this patient with severe dilation of the IVC and the hepatic veins as well. Also, cardiac MRI is very good at looking at the ventricular size, ventricular mass, and ventricular function. And also we can look at the ventricular mechanics and strain with cardiac MRI. And we can use the flow data to evaluate valvular regurgitation and also the burden of the collaterals. So this is that same patient that we looked at the Fontan pathway in before. And as you can see here by this 3D reconstruction, you can see the entire Fontan pathway is actually pretty small. And then there is dilation of the IVC and the hepatic veins. And because it's a venous system with really low pressures, when we go to the cath lab, when we measure the gradients, usually there is like very minimal gradient despite this degree of stenosis. But luckily now we have these advanced tools with 4D flow, which is like, pretty straightforward to do right now. And you can see clearly that there is some flow acceleration starting at the level of that conduit. So you can see it's like, blue and green here, and then you can see that there is a lot of red here over that conduit. And that also, when we do the analysis, correlates with kinetic energy loss over that conduit. And that kind of supports the clinical decision we make in these cases of stenting this Fontan conduit to make it bigger. This is another 4D flow, and from a patient we actually did last week, there was a concern for possible AVMs. So with that 4D flow, we could label the IVC flow, and we can see that there is good flow distribution to both lungs, like with this 4D flow. Similarly, the SVC flow also goes to both lungs. This used to be very time intensive, and like we needed to send it to computational flow dynamics and get the results like 3 weeks later. Now with 4D flow, like we report that in the clinical report same day. So it's pretty quick to do these days. And then the thing that the cardiac MRI can do that no other modality can do is tissue characterization. So you can see this is our patient. So as mentioned before, had a really large scar in the right ventricle. And then this is the normal healthy myocardium. But this picture is without contrast, without giving gadolinium. And this is called T1 mapping. And we can actually now look at the normal myocardium, which is this purple here, while these areas here look thin and also look kind of more orange. So the T1 value for these areas is elevated. So that tells us that there is a scar there even without using contrast. So back to our patient, he was admitted to the cardiac ICU and underwent a successful VAD implantation. And finally, the exciting part is the future directions in cardiac MRI. So we're really trying to use the information from cardiac MRI to guide management post-Fontan, using cardiac MRI for routine screening. So now we can look for any Fontan pathway stenosis, which can limit the ventricular preload and result in Fontan circulatory failure over time. We can also look at maldistribution of pulmonary blood flow, which previous work have shown that it is associated with poor exercise capacity. And we can also use all the measurements that we use by cardiac MRI for volume and strain, as you can see in this paper. If the ventricle is very dilated or if the ventricular strain is low, it's associated with death or transplant. But all these nice studies come from single center. So if we're thinking about the big patient picture as a puzzle, each one of us holds just one little piece of that puzzle. And it's time to really come together in multi-center studies to try to understand the picture and also improve the outcomes. And one example I'm going to mention today is the FORCE registry, or the Fontan Outcome Registry, using cardiac MRI. It started in 2020, and it built a nice research platform in 2022. And now it's striving to become a service for patients and physicians. So let's just look at how the data is structured in FORCE. So the clinical data is housed in REDCap, while the image-based data is actually housed in a cloud-based system called Ambra. The number of patients is increasing rapidly in this registry, and it's now more than 3,000 patients, making it the largest Fontan database in the world. And it's striving to do like automated pre-processing for all the images that we acquire by cardiac MRI. And this is something that takes attending physicians more than an hour to do. And now it's trying to do it through machine learning in about 60 seconds or so. So the workflow will be that the patient will come, get the cardiac MRI, and hopefully the images will go to that FORCE cloud service. They will do that processing really quick and send the information back to the physician very quickly. And because they also have the clinical data about these patients, they will put all of that in a nice risk score, and that will give us like a risk score specific for every patient, let's say for 5-year death or transplant. So that will be an image-based precision medicine for these patients. So to conclude, we covered a lot of ground today. So we looked at the single ventricle roadmap, and we mentioned that imaging plays a central role here in risk stratification and also in detecting complications, in this case, native aortic thrombus, and that our goal is to delay or prevent transplantation and refer at the right time. And also that multi-institutional collaborations are very essential, and we mentioned the example of FORCE, and there's also the Fontan Outcomes Network that Dr. Opatowski leads. And with that, I would like to thank our wonderful Fontan-Kreutzer colleagues and also the FORCE registry team. Thank you.